I took a little bit of presenter liberty and changed the title to Intersectional Stigma because I'm actually going to be touching upon that in more depth, although I will be also mentioning internalized stigma as well. So we are experiencing a proliferation of research on this particular topic. And what we've seen in the past 5 to 10 years are numerous studies documenting that stigma contributes to negative mental health outcomes. In addition, multiple studies report findings of disproportionately high rates of depression, anxiety, and overall psychological distress among transgender people compared to cisgender people. And so I'm going to talk about 3 different types of stigma. Enacted stigma, which is what we think about as the kind of external stigma that people experience as violence, discrimination, harassment, that results from the person's minority status. And anticipated stigma results from the anticipation that people are going to experience enacted stigma. So that anticipation of negative treatment, anticipation of violence and discrimination. And that expectation of stigma creates a sense of vigilance on the person's behalf that is in itself stressful. And anticipated stigma can also result in avoidance of situations where a person expects to experience stigma, like healthcare, for example, or like being in public. And that avoidance in itself can also create negative health outcomes. And then internalized stigma is just what it sounds like. It's taking that stigma that a person experiences and turning it inward, in toward oneself and toward one's own community. And this is potentially the most damaging type of stigma to a person's mental health because it negatively affects coping, it impacts the person's sense of resilience. So I'm going to review some of the data that we have that is documenting these relationships and how mental health also contributes to other types of behavioral health issues like substance use as a form of coping. And I'm also really interested in my research in particular, which is community-based research developing interventions that are trans-led, peer-led, to start interrupting this kind of cycle. I'm interested in asking the questions, what are the protective factors? Dr. Scheim referenced this earlier in his talk. What can we do to intervene upon these relationships? So we all belong to multiple social categories that intersect with one another to create our unique experiences. So we're not just one thing. We're not just trans. We're not just our race or our socioeconomic status. But these different contexts create unique experiences among each person. And so we're looking at people through the lens of trans identities, but there are many, many things about a person's identity or their social position that shapes their experience of being trans. So for people who experience or who have multiply oppressed social identities or social positions as well, like sex work, substance use, socioeconomic status, intersectional stigma can create a social context of increased vulnerability and risk of negative health outcomes such as mental health. So in the US right now, some of you may have heard that we're really experiencing a crisis. This is from the Washington Post, and I disagree with the title. I think this has been a crisis. It is a crisis. It's been a crisis since we started documenting the violence against Black trans women in the US. And in 2017, we had the largest number of transgender women ever documented as murdered. It was 29 transgender women were killed in 2017, 26 in 2018, and in 2019 already there have been 11 transgender women killed at least that we know of. And of all of these women that have been documented in the US as being murdered, the majority of them are Black transgender women in their 20s. And so this is an example, a very extreme, a very emotional example of intersectionality and how it plays out in people's lives. So due to the intersection of multiply marginalized identities, Black transgender women again and again are found to suffer the most severe health disparities in almost every realm that we currently study. And there are some interesting exceptions to that in terms of the research that I'll come back to in a moment. So this is the model of gender affirmation, and this is a conceptual framework that I developed when I was first becoming interested in interventions, in thinking about how to bring programs to community that would really start to think about the heart of trans-specific issues, and also with a focus on community connectedness and empowerment. And so the model of gender affirmation was a way to help me think through how stigma leads to negative health outcomes. And as Alicia mentioned earlier, I'm a clinical psychologist by training, so I'm very interested in identity processes. And there's a concept in social psychology called identity threat. And the way that I was seeing this play out in the trans communities that I was working with and talking to was how stigma creates the social context for decreasing access to gender affirmation while simultaneously increasing the need for it. And so what ends up happening is there's this unmet need for gender affirmation that transgender women, forced by social context, are having to meet in riskier ways, such as substance use for coping, or as was mentioned earlier, turning to sort of risky self-medicating strategies to try and achieve certain aspects of gender affirmation that they're not able to get from medical providers because of the limited social context. So just to kind of go through the literature a little bit documenting stigma, again, I apologize for the focus on the US, but as Dr. Scheim also mentioned, there is an unfortunate reality that a lot of the data, especially around mental and behavioral health, is currently coming out of the US. It's also the data I know the most, so I apologize for the bias, but the 2015 US Transgender Survey was indeed the largest survey of transgender people to date, over 27,000 people from all 50 states, and documented, I will refer to it quite a bit in my talk just because it's so comprehensive in terms of the types of issues that they looked at and the size of the sample. But they found very high rates of physical assault, sexual assault, verbal harassment, employment mistreatment, which in this case covers everything from verbal harassment to being denied a job, being fired for being transgender, or for even experiencing sexual assault on the job. So a very wide range of what was considered employment mistreatment, but very high. A third of people just in the past year had experienced this, of the people who were employed in that sense of the term. Family violence and rejection was also very high, where physical violence from a family member was 10% just in the past year. And 8% of those who were out to their families and lived in the family home had experienced being kicked out of the family. And what we'll see in terms of mental health and behavioral health, family support is extremely predictive of a person's ultimate structural outcomes. So here, the USTS team separated out respondents who reported that their families were supportive versus those who reported their families were unsupportive. And you can see that the respondents whose families were unsupportive were more likely to experience homelessness, more likely to attempt suicide, and were more likely to report that they are currently experiencing serious psychological distress. And these are adult respondents. And so family support throughout the lifetime can predict or is associated with some really important outcomes. This next slide is sort of a compilation of different data sources just to start to get a real sense of the difference between outcomes for trans youth and trans adults as compared to their cisgender peers. And so this data comes from the USTS as well as the Minnesota Student Survey, which was an extremely large data set of students, both trans and gender nonconforming as well as cisgender students. And what they found was that trans and gender nonconforming students reported 3 to 4 times the rate of psychological distress at every data point as their cisgender peers. Similarly, adult trans respondents, even though they're in some ways doing a little bit better than the trans youth, because as a person goes through adulthood, there are certain coping strategies that may kick in, which I'll talk about in just a moment. But the suicidal ideation, that's lifetime. So you can see that for adults, they've had longer to think about it, unfortunately. But there's a huge discrepancy in terms of psychological distress between trans people and cisgender people. And interestingly, when we think about intersectionality and the intersection of trans experiences and age, what we saw in USTS was that the most extreme experiences of serious psychological distress were being reported by the youngest cohort in USTS, and that this actually went down over time. And so as a person ages, the rates at which they were currently experiencing psychological distress went down. And you can see that happens for the cisgender sample as well. But the extreme slope of that curve for trans folks is quite striking. And Joe Olson wrote a really great editorial in JAMA Pediatrics talking about how important mental health providers are for trans youth and how important it is for us to rethink the role that mental health providers play in supporting trans youth, because we come from this history of thinking of mental health providers as gatekeepers, as the folks who decide whether or not a person is trans enough to get treatment, and we heard some discussion about that in the first session, but I really encourage folks to check out that article. She's a pediatrician in Southern California who has had some really great, shared some really great thoughts about this. Interestingly, going back to the concept of intersectionality, some of the more current work looking at gender nonconforming individuals and gender non-binary individuals is starting to show that gender non-binary folks actually experience higher levels of psychological distress than binary identified folks. And this was a retrospective analysis of the 2014 to 2016 behavioral risk factor surveillance system that found that the self-reported health outcomes of gender non-conforming folks in their sample as compared to gender binary were worse, and that they were experiencing more limitations of their poor health outcomes on a day-to-day basis. Here's another example of a very large data set that was used to look at folks who identify outside of the gender binary. And this team found that compared to binary identified cis and trans people, genderqueer participants, which was the term they used to identify gender non-binary folks in their study, reported that higher levels of harassment, sexual abuse, traumatic events, anxiety, depression, psychological distress, higher levels of self-harm and suicidality, and nearly 50% of their genderqueer participants reported having made a suicide attempt at some point in the past. And the authors of this article hypothesized that there are certain structural aspects of the genderqueer experience that might help to explain some of these findings. Things like people just generally not understanding the genderqueer experience, it really existing kind of outside of our framework for human experiences, which we really think of as binary. The lack of knowledge about correct pronouns to use for genderqueer and gender non-binary folks, and just general lack of access to legal and medical resources. So research suggests that those who experience high levels of enacted stigma are more likely to use and abuse substances as a form of coping with that stigma. And Here, there were a couple studies that elucidated this relationship. In one 3-year prospective study of 230 transgender women in New York City, what they called gender abuse, which I'm calling enacted stigma here, was found to be associated with substance use and heavily mediated by depressive symptoms. And then another study in San Francisco of young transgender women reported really high rates of recent drug use, finding that those who were reporting gender-related discrimination or who met the criteria for PTSD were about twice as likely to use drugs, and those currently experiencing psychological distress were more likely to use multiple, what they call heavy drugs. The largest studies that exist of cis adults, the USTS, and actually this was from a cross-sectional sample of youth in California just middle and high school students that compared trans youth to cis youth, found that both trans adults and trans youth are about 3 times as likely to report using drugs as cis adults. Interestingly, in USTS, one of the most striking intersectional kind of analyses that they did of what predicted substance use found that those currently working in the underground economy were most likely to report substance use, which really makes sense because substance use can be thought of, one, as a proxy for marginalization in general, and those working in the underground economy are also marginalized in that sense, and that this also includes people who are currently engaged in sex work, and that substance use has been cited as a way of coping with the stress that can accompany sex work. So let's talk a little bit about resilience and protective factors to lighten the mood a bit, perhaps. All of these data are really striking in terms of how kind of durable the impact of stigma can be on a person's both structural sort of situation and their psychological outcomes due to social oppression and the impact that that has on the person. But there are things that we are starting to identify as resilience and protective factors. And one of those is social support. This looks like formal support in terms of mental health providers. As I mentioned earlier, one of the most important factors is family support, but also peer support and connectedness to trans community is a really important protective and resilience factor. Internal resources like identity pride and positive coping strategies are also contribute to resilience and protective factors. Structural resources such as improving one's socioeconomic status through education and employment. Housing, of course, is incredibly important as a protective factor. And gender affirmation. So gender affirmation can look both like medical affirmation, access to hormones and surgeries, if that's what the person is seeking, but can also look like social affirmation. So having your identity reflected back to you in your interpersonal relationships, that includes with your healthcare provider, with your family, with your peers. And that indeed what we're finding is that these protective factors predict better health outcomes. And the more protective factors that you have in your situation or can bring into your community, the better the health outcomes. So let's talk about social support from peers for a moment. Bakhting and colleagues found that enacted stigma was indeed strongly associated with psychological distress in an online study that they did in the US in 2013, but they also found that peer support significantly mediated this relationship, but only at high levels, not at low or medium levels. So it was really important that this peer support was strong, that it is powerful enough to reduce the powerful effects of stigma. Family, as I mentioned earlier, is an incredibly important resilience factor. We find that this is associated with all sorts of outcomes, that it predicts greater self-esteem, better overall health, that it protects against depression, substance use, both suicidal ideation and suicide attempts, and so that family support has really been identified as a key resilience factor in the face of stigma. So when thinking about interventions, one of the things that we can start to think about is how do we support families, especially for those folks who are working with youth, that not just seeing that the child is actually the one who's telling you who they are and just needs support in that, and sometimes it's really the family that needs support in order to really produce the best outcomes. And trans community connectedness has consistently been found to be protective against depression, anxiety. Social isolation, of course, is often associated with depression and anxiety, and so being connected to community is also a point that we can start to think about intervening upon when we create programs, creating trans-specific, trans-led programs that really focus on community building, community empowerment, can be an incredible resource for people who are otherwise isolated or who have experienced family rejection. So gender affirmation, we've seen an incredible proliferation of studies looking at the positive impact of access to hormones in particular, but also access to other types of surgeries for people who want them, and the incredible sense of relief, the incredible rebound that you see people experience from psychological distress into a new place of health when they get access to the treatment that they need. And this is also true for youth, and this is something that I think this kind of data is really reassuring to providers who tend to be more cautious with youth. But what we are seeing coming out in the data again and again is that youth who have especially the ability to transition socially and are supported in their identity socially at school, with their peers, with their family, as a sort of precursor to making decisions about other forms of medical affirmation, that this is really important to positive outcomes among youth. Social gender affirmation is also incredibly important, and so that looks like peers, family, trans community, connectedness, but it's in particular related to that experience of having one's identity reflected back to oneself in an accurate way. So this is another sort of proxy for looking at the intersectionality of psychological distress with other types of ways of living as a trans person. And so here, this is of course associated with age, but it's also associated with just living in one's own truth. And that the longer that one has lived in that identity, the more years that it's been since they went through the process of transitioning, whatever that looked like for them, that psychological distress goes down over time. And here's a quote from USTS that I felt really exemplifies this idea of the importance of gender affirmation. And this participant said, "I have struggled with depression and anxiety ever since puberty. I've failed classes, isolated myself, and considered suicide because of this. A year ago, I felt hopeless and had daily suicidal thoughts. And today, I've got a plan for the future and haven't had a serious suicidal thought in months. I firmly believe this is because of my transition. I feel so much more comfortable and happy than I've ever been." So if we can support people to have that kind of experience, then we're learning how to do something right. So in conclusion, I just want to say that we know, based on current evidence, that due to stigma, trans and gender diverse youth and adults do experience poor mental and behavioral health outcomes in their cisgender peers, and that intersectional stigma influences who is most severely impacted. And we do know that there are some protective and resilience factors that inform us about how we might be able to intervene. And those are social support, gender affirmation, access to structural resources, and building internal resources. And then just a quick plug for what has really inspired me to do this type of work, both in San Francisco and more recently in Sao Paulo, Brazil. We're working with communities to really put these types of concepts into action in terms of interventions and programs that the community themselves are leading, are dreaming, are guiding. And so it is possible, it's hard work, and it's incredibly rewarding. So I just wanted to give a shout out to my collaborators. Thank you very much.